We are live, sir.
Okay. So, good morning, respected faculty and dear delegates. Welcome to this fine Sunday morning. Today we have a sunny day in Delhi, unlike smoggy days in the rest of the days. I welcome the faculty, Dr. Narayanan and Dr. Manjinder, and the coordinator, Dr. Maninder Singh Dhaliwal. He has been doing a great job. I request Dr. Maninder Dhaliwal to please introduce the faculty and start the proceedings.
Good morning, everyone. Very interesting day today. We have arterial blood gas made easy. It's a very challenging topic, but once you understand it, at least for that particular day, you will love it. After 10 days, again, you will forget it unless you keep on seeing the ABGs again and again. So with that, I'll just first introduce the moderator. The moderator for this session is Dr. Narayanan. He is a very close friend and he's a professor and head PICU at JIPMER, Pondicherry. He has multiple publications. He's a DM teacher also, and he's very practical bedside knowledge. So welcome, Dr. Narayanan. We would definitely like inputs from you on how to make ABG analysis simple. And to decode this topic, we have none other than Dr. Manjinder. Again, he's a very good friend, a very close friend, and he has done his DMPICU from PGI Chandigarh. Then he explored a little bit of the corporate world, and now he's again back in PGI as assistant professor. He is very practical. He'll make ABG very simple, and people are looking forward to hear from you, Manjinder, without wasting any further time. I'll request you to start. And
Dr. Meena.
One word from Dr. Shyam Sundar Meena, please. He is our secretary.
Please unmute Dr. Meena. Please unmute.
Hello.
Yeah, good morning.
Good morning, everyone. Thank you on Indian Pediatrics and come to our panelist as well as chairperson, Dr. Sarkar and Dr. Narayan. And thanks, sir, for agreeing to facilitate today's session. Over to Dr. Man.
Thank you, Dr. Shyam. Despite his busy schedule, he always makes time for us, and he's the most busy secretary of IIP Delhi. Pleasure to hear from you, Dr. Shyam. And let's go forward with permission from Dr. Ajay. Should we start?
Yes, please go ahead.
Dr. Manjinder, over to you.
Thank you, Maninder sir, for the kind introduction, and thank you, IIP Delhi, for this opportunity. Good morning, everyone. I hope everybody has had their morning coffee. It's a Sunday morning, and we are going to discuss a topic that is probably one of the most important topics in PICU. This is something you're going to see left, right, and center, probably more than you should during your PICU practice. So we'll try to kind of divide the topic initially into a little bit of physiology. What are the terminologies that we're going to use throughout this session? We'll go into the technique of doing an arterial blood gas. And after that, we'll go for the stepwise approach towards the interpretation, and we'll discuss a few case scenarios in the end. So the body tries to maintain a very delicate balance of acid base inside the plasma. So the pH is to be maintained between 7.35 and 7.45 for the optimum working of all the enzymes and all the body metabolism systems. The moment it overshoots on either side, there are some issues that are going to happen. A little bit of overshooting here and there, the body will try to compensate and the working window can still be maintained. But once it goes beyond a certain point, the pH becomes incompatible with life and you'll have a fatal scenario. So usually the body tries to maintain a balance between the bicarb and the carbonic acid inside the plasma. The ratio is usually 20:1, and anything that disturbs this ratio will cause an alteration in the acid-base balance and an alteration in the pH of the blood. So the terminology is very simple. Acidemia is decrease in blood pH below the normal range. Alkalemia is increase in blood pH above the normal range. And the processes that cause these changes are termed as acidosis and alkalosis. So usually, hydrogen ions are produced during the metabolism of various body products like fatty acids, amino acids, and during the normal metabolism and transport of carbon dioxide throughout the body, and other organic acids like lactic acid and keto acids. So all these fall into the plasma. And now there are various buffers that try to absorb these hydrogen ions and maintain the plasma pH within the normal range. So these buffers are like bicarbonate in the fluid inside the cells and other places. And the exit of hydrogen ions is usually either through the respiratory system, through ventilation in the form of carbon dioxide, or the kidney excretes the hydrogen ion into the urine. So like we were talking about the buffer system, so there are different buffer systems in the intracellular and extracellular fluids. Intracellular buffer, the most important and biggest buffer is the phosphate buffer system. Along with that, there are various protein buffers, including hemoglobin in the RBCs, and amino acid buffers and all other proteins in the other cells. In the extracellular fluid, primarily it is the bicarbonate carbonic acid buffer system, but other proteins also contribute. So what happens? I'll just use a pointer here. Yeah. So the cells during their metabolism produce acids. They enter into the blood, and those hydrogen ions are absorbed in the form of carbonic acid, which is in a fine balance of breakdown to bicarbonate, carbon dioxide, and water. Now, these hydrogen ions bind to this bicarbonate buffer and enter into the kidney, where the carbonic acid is again broken down by carbonic anhydrase, and this H plus ion is excreted into the urine as required by the body and the requirement according to maintenance of pH inside the body. Now, after the blood exits the kidney, it has less hydrogen ions and more bicarb. And then the other buffers like proteins and other buffers again lead to maintenance of this balance. And this keeps on going around, reaches the lungs, where again it is broken down into carbon dioxide, which is exhaled. So basically, it's the lung and the kidneys that are taking the hydrogen ions out and trying to maintain a fine balance of pH in the body. So why does it matter? Why are we so bothered about the pH of the blood? So any change towards either direction will cause deranged physiology. So acidemia causes decrease in cardiac contractility, increase in pulmonary vascular resistance, leading to worsening of pulmonary artery hypertension, stimulation of the sympathetic adrenal axis. A prolonged acidemia will cause catecholamine insensitivity, and the oxygen dissociation curve shifts towards the right, leading to desaturation along with altered mental status. On the other hand, alkalemia causes arteriolar constriction, reduction in the coronary blood flow, reduction in the pulmonary vascular resistance, which can cause VQ mismatch, impaired in the hypoxic pulmonary vasoconstriction, again causing VQ mismatch, and eventually leading to reduction in cerebral blood flow if it is of respiratory origin and it is prolonged. So what changes the outcome of any child who has either acidosis or alkalosis? One is obviously the severity of the pathological derangement. Second is the acuity and duration. So how fast this derangement occurred. So pH was 7.4. Let's say it gradually changes from 7.4 to 7.3 to 7.2, like you see in a lot of patients with renal tubular acidosis. So the body sometimes adapt to these pH changes, so the severity of the illness may not be as much. On the other hand, in a patient who has had sudden fluid losses due to acute gastroenteritis, and the pH has dropped from 7.4 to 7.2 within a few hours, you will see that the acidosis at the same level causes more physiological or pathological derangement. And of course, the duration. If the acidosis remains for a longer duration of time, the derangement will be more. The functional status of the lungs and kidneys, because these are the organs that are going to take the hydrogen, maintain the balance of the hydrogen ions. If one of these is not working, the balance gets disturbed, and the body's ability to compensate for a change in pH goes haywire. And obviously, the underlying etiology, if it's a mild benign etiology, usually the body takes care of it. And if it's something severe or persistent, then it causes more problems. So where does the role of a blood gas come? So basically, one, it aids in obviously establishing and based on the blood gas, you can formulate your treatment plan and take it further. So when we talk about blood gases, let's start with sampling for blood gases. So what sample to take? So you have the arterial system, you have the venous system, and then you have the capillary system. So arterial samples are the ones which you usually see in standardized text, and all the normal values that we talk about usually are based on the arterial sample. So the normal pH is 7.4, PO2 is around 80 to 100 when you're breathing room air. Oxygen saturation is anywhere above 95%, CO2 35 to 45, bicarb around 24, and base excess is usually 0 or within plus minus 2 of that. The venous side is slightly more acidotic because of all the metabolism that is occurring in the body, and the saturation is slightly lower, CO2 is slightly higher. So depending on which blood gas you are analyzing, you can have different values, and you should be aware of these normal values. When you're trying to see a child with respiratory failure, this is where you need an arterial blood gas, because you want to see the oxygenation parameters, you want to see the exact carbon dioxide, and all these normal values are based on arterial blood gases only. On the other hand, if you're trying to evaluate a patient with, let's say, DK, then venous blood gases are good enough. And in fact, the values of DK that you all are so aware of, like 7.3, 7.2, how we divide it into mild, moderate, severe, all those values are based on venous blood gases. So you do not need to prick arteries in all patients. Arterial blood gases need to be reserved for patients with respiratory problems and where you're trying to assess the functioning of the respiratory system. For most of the other patients, venous blood gases and trend of venous blood gases suffices. So then comes the capillary blood gas. So if you are unable to do an arterial blood gas, like in neonates or in young patients, that is where you can substitute it with a capillary blood gas. So capillary is closest to artery, and this is when the sample is taken properly. So you've warmed the limb, you've done a good puncture, and there is free flow of blood. That is where capillary blood gases come close to arterial blood gases, and you can kind of use these in place of arterial blood gases if those are not available to you. So as we've discussed, in diabetic ketoacidosis and other places like diarrhea, dehydration, chronic kidney disease, renal tubular acidosis, IEMs, you can actually use venous blood gases, and you don't need to prick arteries every single time. So let's come to the radial artery sampling. So this is the artery that is most commonly used for arterial blood gases. So the sampling procedure obviously is based on the adults, and you can use the same procedure for bigger children. Sometimes it's challenging to use this process for very small children or for neonates, but the overall kind of way remains the same. So you position the patient's hand with the wrist extended a little bit, 20 to 30 degrees, not extreme extension. If you go for extreme extension, sometimes you will compress the artery and you may not get the pulsation right. So palpate and choose the site where the pulse is prominent. Clean that size, obviously, with an alcohol wipe or whatever your asepsis protocols are. Ideally, inject 1 ml of 1% lidocaine at the site so that the patient does not feel any pain. Then insert the needle at a 45-degree angle, and the bevel of the needle should be facing upwards. And then insert it slowly to minimize the risk of 1, arterial spasm, and 2, overshooting the artery and puncturing the posterior wall. So this is how you position the hand, and you place two fingers. Some people say that you place the two fingers a little apart and prick in between the fingers. And sometimes this is the way they say. I mean, you can do it the way that you like, but the important thing is that palpate, choose the right side. The extension should not be too much, and puncture at a 45-degree angle with the bevel up and go slow so that you do not cause arterial spasm and you do not puncture the posterior wall. Before pricking the radial artery, it is always a good idea to perform the modified Allen test. Basically, this test is to see whether the circulation inside the hand can be sufficiently supplied by the ulnar artery if the radial artery goes into vasospasm or there is a thrombosis. So this is the way you press both the radial and ulnar circulations firmly. Once the hand is blanched, you see this has become white, you remove the ulnar side. And once you remove the ulnar side, if there is recirculation of the hand, if it becomes red again, that is a negative modified Allen test, which means the ulnar circulation is good enough, you can prick the radial artery. If the hand remains blanched, it remains white for more than 5 to 10 seconds, that usually means that the ulnar circulation is not sufficient to supply this hand. And thus, in these patients, you should not prick the radial artery, because if you puncture, if you cause thrombosis or if you cause vasospasm, you can cause ischemia in the hand muscles. So these are the contraindications if there are inadequate collaterals when you're assessing with the modified Allen's test. If there is peripheral vascular disease resistant to the puncture site, or if there is significant coagulopathy, or the patient is on medium to high dose anticoagulation therapy. In these patients, you should be very, very, very cautious before pricking any artery. After the sampling, obviously, you should apply firm and direct pressure to the sample site for at least 5 minutes. There should be no air bubbles in the sample, and you should analyze the sample promptly. So after this, we'll see one by one what all problems can occur if we sample the patient wrongly. The first one, obviously, if you're trying to assess a change in arterial blood gas after you've done a certain change in the ventilatory settings of the patient, wait for at least 30 minutes after that change. If you do sampling before that, you will not get the effect that your change in ventilatory settings has caused. So wait for at least 30 minutes after you tweak your ventilator to see the effect of those that change in settings onto your blood gas. Second, and probably the most common error, is improper heparin. So the problem with heparin is that, one, it is a liquid solution, so it will dilute everything. It will dilute your electrolytes, bicarb and carbon dioxide, so everything will go low. Second, because it is sodium heparin that is most commonly used, the sodium may be falsely high when you use too much of sodium heparin. Third, heparin itself is a binder, so it binds to your cations like calcium and potassium. So if you will have falsely low calcium and potassium levels, and the risk of alteration of results increases with, one, size of the syringe and needle, and two, if the volume of sample that you've taken is too small. So how do you change it? The best way is to have pre-filled syringes with dry heparin. So the liquid part, dilution part goes away, and this dry heparin is generally lithium heparin, which binds to these calcium and potassium lesser and thus causes lesser alteration in your electrolytes. If you're using liquid heparin at all, if you don't have these pre-filled syringes, all excess heparin should be completely expelled from the syringe, and only probably a tiny drop in the dead space of the syringe and the needle is enough. No more than this is required. As I said, lithium heparin is the current recommendation, but usually sodium heparin is what we get in our wards, and this is what we use usually if we are not using pre-filled syringes. Then the next problem that occurs is, a lot of times we sample from the arterial lines. So when we are sampling from the arterial lines, the sampling site is a little away from the arterial catheter. The three-way is placed around 10 centimeters away from the arterial catheter, and there is a solution that you're running through your arterial line. It can either be Heplock or sometimes you just run normal saline. Now this solution is there all through the line. And if you don't remove this solution completely before taking your sample, you will get dilutional effects, and all these will alter your blood gas results. So you discard at least 2 to 3 times the dead space volume when sampling from an arterial catheter and not sampling by directly pricking the artery. Then another very common problem is the presence of air bubbles in the sample. So even very small bubbles, as much as 1% of the total sample volume, can cause alteration in your blood gas values. So what will happen is everything will migrate towards room air. So anything, if PA2 is greater than 100, it will come down. If it is less than 100, it will go up. Same with CO2, it will all come towards 40. And the pH will change according to your CO2 changes. So you will have an altered blood gas result, and you will maybe change your therapy according to the wrong blood gases. So every time you take a sample, one, try to nullify the effect by taking out the air bubbles immediately after you've taken the sample. Expel them by gently tapping. Do not vigorously shake the needle, otherwise all the air and everything will mix. Just gently tap, bring the bubbles to the top and take them out. And after you've taken out the bubbles, seal it immediately with the cork or cap so that more air does not get in. The next problem usually seen is hemolysis, which is a significant source of error. So the main thing that changes with hemolysis is potassium. You will have false elevated potassium level if you keep the sample for too long, or if you keep them directly over ice. Obviously, cold temperature will cause hemolysis. So this will cause a falsely elevated potassium level. So one, do not place it directly on ice cubes. Two, avoid vigorous mixing of the sample. So don't take the syringe and shake like this. And then don't use a very narrow needle, or don't use a very negative vacuum when you're taking an arterial ABG sample. Usually, if you're using a 1 ml syringe and you're using a 24 gauge needle, the moment you prick the artery in a child who's probably more than 4 or 5 years of age, it'll fill up by itself. You don't even have to pull the plunger. If you pull the plunger too hard and create a very negative pressure, you will cause hemolysis. The next common error is delayed analysis. So I have I always keep remembering one of my friends during my internship. So he was doing the night sampling in the medicine ward, and he was taking 2 samples for blood gas for each patient. I asked him, what are you doing? He said, मैं सुबह का sample भी अभी ले रहा हूँ. So that is not how it needs to be done. One, you need the current situation of the patient, of course. And two, the more you delay the analysis of the patient of the blood gas, you will keep getting altered results. So for every 1 hour delay, if you keep the sample at 37 degrees, that is normal body temperature, for every 1 hour delay, your pH falls by 0.05, your CO2 rises by 5, and your PO2 also comes down. So analyze every sample within 30 minutes of specimen collection. And if you have to store the sample for those 30 minutes, it is always better to put it in an ice pack or refrigerate at 4 degrees and analyze as soon as possible. So this is a common picture that you see. You have a PICU that is, let's say, 8-bedded, and in the morning your resident comes rushing to you with 6-7 blood gases and hands them to you, and you're just swimming in a lot of numbers. So let's not get overwhelmed by the numbers, and let's see how to go about this step by step. So usually what you need to know from your blood gas: one, whether the patient has a normal pH or he has acidosis or alkalosis. Two, what is causing this derangement, whether it's the respiratory system or the metabolic system that is causing the problem. Next, has the body been able to compensate for this derangement? So whether it is compensated or decompensated. And last, whether it is a simple single system problem or it is a mixed problem that is being caused by multiple things that are going on in the body. So these are the main 4 questions that you need to answer when you look at any blood gas that your resident brings you. So let's go one by one. So respiratory, anything that is caused by the lungs. So retention of CO2 is usually the most common problem, or hyperventilation causing fall of CO2. Metabolic is what changes your bicarb first, usually the kidney or other systems like sepsis and all. And the problem is actually in the bicarb, and the lung is the one that is compensating. So compensation is the body's attempt to return everything to normal pH, that is 7.4. The moment there is a derangement, all regulatory mechanisms start action. And when there is metabolic derangement, there is respiratory compensation, and vice versa on the other side. So usually the compensation does not overshoot. So let's say you have metabolic acidosis, and because of your respiratory compensation, your pH will not go towards alkalosis. So again, as we discussed, simple disorder is single primary process, and mixed disorders are when more than two processes are coming into place. So let's go with the steps one by one. So the first step is usually checking the internal accuracy of the report. If your ABG machine is calibrated regularly and you have a technician that is taking care of the machine, this step is usually not required, and your if a well-calibrated machine usually will be accurate. Then the first step is look at the pH and decide whether the patient has acidosis or alkalosis. Okay. Then identify whether this acidosis or alkalosis is being caused by a metabolic derangement or a respiratory derangement. Then identify whether this is compensated or not compensated. Then when there is metabolic acidosis, we talk about anion gap. And then we see whether this is a simple or mixed disorder. And eventually, to unravel a mixed disorder, we calculate the delta gap and delta ratio. So let's go through this one by one. So this internal accuracy part, you can see and forget. Mostly this is not useful in your daily routine. So what you do is you calculate the H plus ion. So this is the formula 24 into PaCO2 by bicarb. And corresponding to that H plus ion, the pH according to this table should be the pH on your report. If this is corresponding, your report is consistent. And as I said, if your machine is being regularly calibrated, you can just skip this step in your blood gas. Next is see whether there is acidosis or alkalosis. So the normal range of pH is between 7.35 to 7.45. But usually for ease of analysis, we take a cutoff of 7.4. So 7.4 is normal. Anything above 7.4 is alkalotic. Anything below 7.4 is acidotic. So next, let's see what is the primary thing that is causing the problem. Okay. So if it's a respiratory acidosis, your CO2 should be high. And to compensate for that, your bicarb should also be going high. If it's a metabolic acidosis, your bicarb should be going down. And to compensate for that, your CO2 should also be going down. So if you see, if it's a single primary disorder, both your CO2 and bicarb are going in the same direction. If the CO2 is going up, the bicarb is also going up. If the bicarb is going down in metabolic part, the CO2 is also coming down to compensate for it. Okay, same for alkalosis. It's just in the opposite direction. So how do we check for compensation? So obviously the body will try to bring the pH back to normal, as we've discussed. So most commonly you will deal with metabolic acidosis, and to check for compensation, you have to see whether the CO2 has come down in the same terms as bicarb. So the formula, this is called the Winter's formula, is 1.5 times bicarb plus 8 plus minus 2. So we will see examples of these formula in the case scenarios we will discuss after a little bit. In metabolic alkalosis, the CO2 should rise by 7 for each 10 rise in bicarb. These are the values that you just need to remember. You don't commonly face these scenarios like metabolic alkalosis and all. The most common scenario again will remain metabolic acidosis and respiratory acidosis. So in acute respiratory acidosis, for every 10 rise in CO2, your bicarb should rise by 1. In chronic, because obviously if it is lasting for a long period of time, the body will compensate with bicarb better. So bicarb will rise by 3 for every 10 rise in CO2 if it is a chronic respiratory acidosis. For respiratory alkalosis in acute phase, the bicarb falls by 2 for every 10 fall in CO2. Similarly, for a chronic respiratory alkalosis, the bicarb falls by 4 for every 10 fall in CO2. So you can kind of remember this in your own way. In my head, I always remember acidosis, alkalosis, acute and chronic, 1, 2, 3, 4. So 1 for acute respiratory acidosis, 2 for acute respiratory alkalosis, 3 for chronic respiratory acidosis, and 4 for chronic respiratory alkalosis. You have to kind of formulate your own mnemonic or something to remember this inside your head. But if you want to forget everything else, the one that you should remember, the one that you face most commonly is acute respiratory acidosis, and that is bicarb will rise by 1 for every 10 rise in CO2. The next step is calculating the anion gap. So the body has multiple cations and multiple anions, but it works on the principle of electroneutrality. So the anions and cations are usually equal to each other in terms of electroneutrality inside the body. Now, you can't obviously measure every single anion and cation inside the body. So the surrogates for anion gap usually are sodium, potassium, chloride, and bicarbonate. Potassium plays a very small part here because the value is very little. So eventually you're left with sodium, bicarb, and chloride. So sodium minus the sum of bicarb and chloride is the anion gap. And the normal figure for an anion gap is 8 to 12. And any anion gap more than 20 is usually always seen in metabolic acidosis. So even if you have any other derangement and you are seeing a very high anion gap, there is a metabolic acidosis hiding there somewhere. So when do we see normal anion gap metabolic acidosis? All your diarrheas and renal losses. So any loss of bicarb through the gut or kidneys, loss of cations through the gut without a proportional loss of chloride, like you see in acute diarrheas, the loss from ostomy, so ileostomy, colostomy losses, or enterocutaneous fistulas, or when you've given an exogenous chloride load. So like we see when we give too much normal saline. So if you, I'm sure in one of these sessions, balanced crystalloids and all those things must have been discussed. So if you give abnormal saline, as we like to call in the intensive care circles, if you give 0.9% saline to a patient, you will see the chloride slowly rising, and eventually you will land up in a normal anion gap metabolic acidosis due to the hyperchloremia. Or again, parenteral nutrition, which has a lot of chloride, so exogenous chloride load. High anion gap, the most common scenarios are lactic acidosis, which you see in liver failures and which you see in your septic shocks. Ketosis, like in DK, toxins like salicylates, and some other drugs. So basically, the added acid, which is buffered by bicarbonate, the bicarbonate falls and the anion gap increases. So this anion gap is caused by an additional acid that is being produced in addition to the normal anions and cations that are there. The usual mnemonic is mud piles, methanol, urea, and the likes. So the next step is to see whether it's a simple or a mixed disorder. So mixed acid-base disorder occurs when there is absence of compensation, excess compensation. There is a problem in either the lung or the kidney, which is causing inappropriate or incomplete compensation, or you are altering this by either assisting, by delivering mechanical ventilation, or you've given some fluids or something from outside, which is changing the acid-base balance of the body. So these are different settings. We don't need to go through each one of them, but the common scenario again, in patients with shock and cardiopulmonary arrest, usually you will find metabolic acidosis along with respiratory acidosis. Like let's say your ARDS patient starts going into renal dysfunction and he has a shock as well. So you will see this scenario very commonly, severe pulmonary edema and poisonings. And in some toxicities like salicylate intoxication, the baseline metabolic acidosis is also complicated by a respiratory alkalosis. So you'll see these scenarios very frequently in your ICUs. So the next step to unravel that mixed picture is calculating the delta gap and delta ratio. The delta gap is nothing but the actual anion gap minus the normal anion gap. So we take 12 as normal, and the delta ratio is this delta gap divided by the change in bicarb. So 24 minus the measured bicarb. So again, we will see kind of come back to this formula when we discuss our case scenarios. So the delta ratio value, if it is less than 0.4, it is generally a pure normal anion gap metabolic acidosis. If it is between 0.4 to around 1, there is a hidden high anion gap metabolic acidosis there that you're unable to see, or it's a mixed high and normal anion gap metabolic acidosis. Between 1 and 2, it is usually uncomplicated high anion gap metabolic acidosis. And anything more than 2 is generally a metabolic alkalosis or respiratory acidosis that is hiding on top of your usual metabolic acidosis. Okay. So these numbers, less than 0.4 is pure normal anion gap. 0.4 to let's say 1 is mixed high and normal anion gap, and 1 to 2 is pure high anion gap metabolic acidosis. So before we start off with the cases, if there are any brief questions, maybe we can take these, or if there are any comments from any of the panelists, Narayanan sir or Maninder sir, we can kind of pause here for a little bit.
So, hi. So, Narayanan, do you have some question? Okay. So, Manjinder, I have one question. When you read a ABG, there's actually in the ABG multiple times there comes actual bicarb, standard bicarb. So, in interpretation, which bicarb should we use? Because sometimes the difference between the both is 2 or 3, and the calculation changes.
Yeah. So I think in most of the units, and the usual practice is to use the standardized bicarb, because sometimes the actual bicarb may vary based on the temperature, based on your machine calibration. So generally, what we use is we use the standardized bicarb to interpret the ABGs.
Okay, perfect. Because many other times we have these doubt. And
Yeah.
second, one more doubt is in BK, the sodium value which comes in a ABG,
Mhm.
should we correct it before calculating the anion gap?
Okay, that's a very good question. So while calculating the anion gap, no, because that pseudo-hyponatremia is what is actually present inside your body because of the excessive osmolar load of the sugar. So while calculating an anion gap, we don't correct for sodium, but otherwise we use corrected sodium to trend it and to see whether your corrected sodium is also coming back, or kind of the gap is closing down when you're treating that DKA patient.
Because again, many people, students get confused. So should we do that or not? So like that, I think so there'll be many questions. So let's proceed with the case.
All right. So let's start with the first case. So you have a 6-month-old child who has a history of persistent diarrhea. So he has had diarrhea for a long period of time. And now he's brought to the emergency room with fungal sepsis and shock. This is the blood gas. The pH is 7.1. The PO2 is 92. CO2 is 19. Sodium 148, potassium 3, chloride 110, and the bicarb is 6. So when you're evaluating this blood gas, let's see what you have. So anybody wants to kind of attempt, you can write in the chat box also.
So they'll be writing in Q&A. I have access to that. I'll tell you the
Okay.
answer if somebody writes.
Sure, sir. So we'll wait for maybe 10 seconds if somebody wants to answer. Otherwise, we'll go ahead.
So people are writing metabolic acidosis.
Okay, very good. So let's see.
Uncompensated metabolic acidosis.
Okay. Okay. So let's see how to go about this step by step. So as we had discussed, the first step is Again, data consistency. You do this formula, you see this table, this data is consistent. So we'll not go through this step. Next is whether this is acidosis or alkalosis. So the pH is less than 7.4. 7.1 is the pH. So this is definitely acidosis. There is no question. So now what is the primary disorder? So you know that for acidosis, bicarb, if the bicarb is low, it is metabolic acidosis. And for respiratory acidosis, CO2 should be high. So here you see both bicarb and CO2 are low. So the primary pathology here is a low bicarb. That is why we are labeling this as metabolic acidosis. What was the next step? We have to see whether the compensation is appropriate or not. So to see compensation, formula, and the actual CO2 should be 1.5 times bicarb plus 8 plus minus 2. So here your bicarb is 6. 1.5 times 6 is 9 plus 8 is 17. So 17 plus minus 2. So your CO2 should be somewhere between 15 and 19. So here your CO2 is 19. So that means the compensation is appropriate for this given bicarb. So you will label this as metabolic acidosis with appropriate respiratory compensation. The next step is to calculate the anion gap. So here the sodium was 148, chloride was 110. So this leads you to a difference of 38, and your bicarb is only 6. So your anion gap is coming out to be 32, which is very high. Your normal anion gap is 12. So this is a high anion gap metabolic acidosis. Now we have to see whether this is simple high anion gap metabolic acidosis or there is some hidden normal anion gap lying somewhere. So for that, we will go to our delta gap and delta ratio. So the delta gap here is the calculated anion gap, which was 32, minus the normal anion gap, which is 12. This is 20. And the delta ratio is the delta anion gap, which is 20, divided by delta bicarb. So delta bicarb is normal bicarb, 24, minus the actual bicarb, which is 6. So 20 divided by 18, which is 1.1. And as we had discussed, anything between 1 and 2 is pure high anion gap metabolic acidosis. So thus, in this patient, the final impression is metabolic acidosis with appropriate respiratory compensation with a pure high anion gap, which is present. If there are any questions here, this was the simplest case scenario. Then we move on to the next question.
Nobody's answering. You can go on.
Okay, so let's go on to the next case. Now, this is an 8-month-old female child who has come with acute gastroenteritis with septic shock. Now, the blood gas here is a pH of 7.29, PO2 92, CO2 33, bicarb 15, sodium 144, potassium 4, and chloride of 108. So what is the interpretation of this blood gas now?
We'll wait for 10 more seconds.
Right.
We want participants to please type. They are again writing metabolic acidosis.
Okay, so they are absolutely right. So if you skip this step, so the first thing, pH is less than 7.4, so this is acidosis. The primary disorder, again, here the bicarb is low. Okay, so this is metabolic acidosis, right? So the next is to see compensation. Again, go back to the Winter's equation. 1.5 times 15 is around 22, plus 8 is around 30, 30.5, plus minus 2. So you get a value between 29 and 33. Here again, CO2 is 33. So you have a metabolic acidosis with appropriate respiratory compensation. The anion gap here, 144 minus 11133 minus 15 is 18, which is again a high anion gap metabolic acidosis. Let's see whether this is a simple high anion gap acidosis or a mixed one. So here your delta gap is 18, which was your calculated anion gap, minus 12, which is 6, divided by difference in bicarb, which is 24 minus 15, which is 9. So 6 by 9 is 0.6. So as we had learned, anything between 0.4 to 1 is actually a mixed acidosis. So this one is a metabolic acidosis with appropriate respiratory compensation. This is actually a mixed high with normal anion gap metabolic acidosis, and the respiratory compensation is appropriate. So here, when you looked at the initial scenario, and a patient with acute diarrhea should have presented with normal anion gap metabolic acidosis only. So when you see high anion gap, this high anion gap is actually masking your normal anion gap metabolic acidosis. So there are both processes going on in the body. And that is where the importance of the delta gap and delta ratio come. And you can actually see that there are two things going on here in this patient. The next patient here is Varsha Devi. She has come to you with the swelling over her scalp for the last 15 days, and she also has developed fever for the last 10 days, and now she has rapid breathing. She has tachycardia, tachypnea. There are severe intercostal retractions. CFT is around 3 seconds. And this is your blood gas. pH of 7.33, PO2 of 85, CO2 of 50, and a bicarb of 24. So on the face of it, what do you think this is?
Respiratory acidosis, they are typing.
Very good. Respiratory acidosis. Do you think this is compensated or uncompensated before we go on to the steps? Even without doing any calculation, in this particular scenario, can you tell me whether this is compensated or uncompensated?
Uncompensated.
Very good. So if you see, the bicarb has not moved from the normal value of 24. So if it's not moved, obviously the body has not had time to compensate for this respiratory acidosis. So again, if you go by the steps again, obviously this is acidosis, pH is less than 7.4. The CO2 is high. So that is the primary disorder. So this is respiratory acidosis. Compensation, as we saw for acute respiratory acidosis, for every 10 rise in CO2, the bicarb should rise by 1. So here the bicarb has not risen at all. So that is why this is an uncompensated respiratory acidosis. So let's say now you've intubated and ventilated this patient. The patient has now stabilized, and your next blood gas is now showing a pH of 7.43, a PO2 117, a CO2 of 35.4, and a bicarb of 23.5. So what do you think has happened here?
We'll wait for them to type. Please type in the Q&A section. Okay, nobody's answered. You can go forward.
Okay, so again, the report was internally consistent. So here, if you see the pH of 7.43, so it is within 7.35 to 7.45. If you want to call it alkalosis, or this is, eventually you will end up with mild respiratory alkalosis, but this is essentially a normal blood gas. Your initial disturbance has now been corrected because you had started from a pH of 7.33, okay? So let's go to the next case. So this is a 9-year-old girl who's a case of tetanus with autonomic instability. And she has unfortunately suffered a cardiac arrest, and now she's with you in a post-cardiac arrest state with septic shock. So this is her blood gas, a pH of 7.21, a PO2 of 119, a CO2 of 45, a bicarb of 18, sodium 145, potassium 4.7, chloride 107. So Anybody wants to interpret this blood gas? Okay,
Mixed metabolic respiratory disease.
Very good. So I think you guys are already experts in blood gas, but let's go step by step again. Acidosis or alkalosis, pH is less than 7.4, so this is acidosis. The primary disorder here is now confusing. So your CO2 is also high, which is respiratory acidosis, and your bicarb is low, which is metabolic acidosis. So how will you decide what is the primary disorder here? So you have to go to your case scenario. So in your case scenario, this patient has septic shock. This patient has suffered a cardiac arrest. So most likely, and you're ventilating this child. So you are doing your bit. So most likely the derangement, at least based on the pathology of the patient, will be primarily metabolic. So you go with primary metabolic acidosis and you calculate your compensation accordingly. So we go back to your Winters formula. Once you calculate, your CO2 should be between 33 and 37. Even if you do not calculate, a compensation for a metabolic acidosis should have been a fall in CO2. Now that the CO2 is not falling instead it is rising. So obviously this is a mixed disorder. So this is a metabolic acidosis with respiratory acidosis. The anion gap here is 20, which is high anion gap. And if you calculate the delta ratio, this is a pure high anion gap metabolic acidosis with no respiratory compensation. In fact, there is respiratory acidosis here. Okay, so this is a patient with a mixed disorder. So this next patient is an 8-year-old girl child who's come to your emergency with cough and running nose for the last 3 days and difficulty in breathing for 1 day. She has tachycardia, tachypnea, CFT is more or less normal. There are retractions both intercostal and subcostal, and there is decreased air entry bilaterally, and there is wheeze. So the ABG here is a pH of 7.42, a PO2 of 95, a CO2 of 26.9, and a bicarb of 17.2. So what do you think is happening here? Okay, so someone is saying normal ABG, someone is saying mixed alkalosis and respiratory alkalosis with metabolic. Okay, this was the last one. Okay, so let's see. Let's again go step by step. Okay, so again, consistency was established. So what is the primary disturbance here? So again, we take a pH of 7.4 as normal. This is slightly above. So let's say this is alkalosis because obviously your CO2 and bicarb are all haywire. In the previous example where we called a pH of 7.43 normal, your CO2 and bicarb were also normal. So when you have a derangement, you have to label it, and to label anything above 7.4 is alkalosis. And here, in terms of alkalosis, your CO2 has fallen. So this is a primary respiratory alkalosis. Now, what should happen when there is respiratory alkalosis? What should happen to the bicarb? To compensate for it, the bicarb should okay. So for every 10 fall in CO2, your bicarb falls by 2 if it's a acute respiratory alkalosis, right? So here PCO2 fall was around 13, so bicarb should have fallen by 3. But now this bicarb has fallen by more. It has fallen by 7, right? So this is something, this looks like overcompensation. But as we discussed earlier, the body never overcompensates unless there is a secondary disorder. So here in this patient, you will label this patient as a respiratory alkalosis along with the metabolic acidosis. Okay, so there is a mixed picture here. There is an apparent overshoot in compensation, and as a rule, the body never overcompensates. So if there is an apparent overcompensation, you will label it as a mixed picture. Like in this case, this is a respiratory alkalosis along with the metabolic acidosis. So let's see one more case. This is a 1.5-year-old boy who's come to the emergency with fever and cough for 1 month. On examination, this child has severe pallor, heart rate, there's tachycardia, tachypnea, there are retractions, and the air entry is decreased. So this is the blood gas. pH is 7.19, PO2 is 123, CO2 is 47, and bicarb is 18. Any takers? Mixed respiratory with metabolic acidosis. So very good. So let's see. Again, let's go step by step. So consistency is there. The primary disturbance, pH is low. So this is acidosis. This is CO2 is going up and bicarb is going low. But in this patient, what was the primary concern? This was a respiratory problem, right? He had come with fever and cough, and he had severe respiratory distress, retraction, decreased air entry. So this you will label as a respiratory problem. Okay. So whether this is compensated or uncompensated. So if you take it as an acute respiratory acidosis, for every 10 rise in CO2, bicarb should rise, right? But here the bicarb is falling. So obviously this is an uncompensated mixed picture. This is a combined respiratory and metabolic acidosis, as someone had very rightly answered in the Q&A section. So now this patient obviously presented to you in shock. You gave him a little bit of fluid boluses, but the child deteriorated because he had severe anemia and he started developing signs of failure. You've added vasoactives now. The child required ventilation. You've intubated and mechanically ventilated. Now you've given a blood transfusion. And now on day 2, you've done another blood gas, which is showing a pH of 7.34, PO2 of 147, CO2 of 55, bicarb of 28. And your sodium is 154, potassium is 4.8, and chloride is 116. So let's see. So there is someone is saying respiratory acidosis with metabolic compensation. Okay, let's see. So obviously your data consistency was established. The primary disturbance here is acidosis. It is respiratory because the CO2 is high. Your primary pathology was also respiratory distress. So now for every 10 rise in CO2, your bicarb should rise by 1, right? For acute situations. So in this case, your CO2 is around 55. So your bicarb should rise by around 4. And this is all, the rise is also of 4. So bicarb has gone from 24 to 28. So this is a compensated respiratory acidosis. So whether this is simple or mixed, because there is adequate compensation, this is a simple respiratory disorder. What is the anion gap? The anion gap is 10, which is the normal anion gap. So now the child is being weaned from the ventilator. It is already day 7. And your pH is 7.51. O2 is 78, CO2 is 38, and bicarb is 31. So what do you think is happening here now? So let's see again. Go through the steps one by one again. Data is consistent. The pH is more than 7.4, so this is an alkalosis. Now, CO2 is more or less normal and the bicarb is high, right? So this is a metabolic alkalosis. And since the CO2 is more or less normal for this metabolic alkalosis, for every 10 rise in bicarb, the CO2 should rise by 7, right? But the CO2 is not risen at all. So this is uncompensated metabolic alkalosis. So this is a situation that you see very often in your ICUs when the CO2 has been high for very long. The bicarb rises, but once the CO2 comes back to normal, the bicarb takes a little bit of time to come back to baseline because the lung acts very fast because it can eliminate CO2 fast. But kidneys take a little bit of time to maintain that bicarb and H plus ion balance. So this is a very common scenario after a patient has had high CO2s for a considerable amount of time, and this is called a post-hypercapnic metabolic alkalosis. So this brings me to the end of this presentation. Obviously, a stepwise approach is always the best idea for acid-base disorders. Avoid sampling errors like we discussed, air bubbles, excess heparin, delayed processing, all these errors need to be avoided because it will alter your blood gas. And if you have an incorrect blood gas, you will make incorrect changes to your patient. Always interpret with the clinical scenario. As we saw, there were a couple of mixed pictures. So the primary pathology is what determines the primary acid-base disorder. And see whether the child is doing well or not, and that is most important. And always treat the patient and not the blood gas values. Thank you.
Thank you, Dr. Manjinder. I think so. Narayan is in the airport.
Yes. I reached the airport. Yeah, but I was listening. Very excellent presentation, Manjinder. You covered all the aspects. The cases were very carefully selected. The discussions. So I have nothing much to add rather than just emphasizing some of the points which is already mentioned. Even to the end, he mentioned that always see the clinical scenario, and once I know the patient well, and then go and look at the ABG. So that it will be much easier if you do like that, and confusion will be much less. And I think you already told them, but I think it is important for them to know why it's important to know this. Increased anion gap and normal anion gap metabolic acidosis is why is it important to differentiate. I'm not sure if you said that because in between, I lost you for some time. I think for those of the students who are listening, whenever we have a metabolic acidosis, it can be of two mechanisms. I'm sure Manjinder might have already told you, but I'm just reiterating that because that is one of the commonest we encounter. Either we can lose the acid, alkali from your body, that can lead to acidosis, or you can gain acids. So in all conditions where you gain acid as a mechanism, you'll have an increased anion gap. So, and whenever you lose alkali from your body, and that is the cause of acidosis, you'll have a normal anion gap. So the treatment for both are totally different. That's why it's important. For example, if the cause of acidosis is loss of alkali from your body, like what we see in renal tubular acidosis, we need to supplement, by carb. But in other situations, we may find out what is the extra acid which is accumulated, and we may try to treat the cause or try to remove it. So that's the reason why it's so important for you to know measure the anion gap, because many times it doesn't say why I should unnecessarily measure the anion gap. I know it's metabolic acidosis because the treatment is different. And please look at the clinical scenario. Even though ABG may sometimes look complex, once you understand, look at the patient and then guess what could be going on, then it's easy for you to figure it out. And what Manindra said, I want to re-emphasize that again. Unless you keep seeing ABGs, this will just evaporate in 1 week. So today you'll feel very confident because Manindra has done such an excellent job. You feel that you've conquered ABG forever, but that's not going to last unless you keep looking at ABGs and interpreting them and discussing with somebody senior if you are unable to figure it out. I think that's my 2 cents, I guess.
Perfect. Thank you, Narayan. Despite your travel schedule, you took time and attended this webinar, and points well taken. And Manjinder, 2 points regarding the
Please stop sharing the screen.
Regarding the co-oximetry, carboxy and methemoglobinemia, that usually people get confused in North India. So it's important if your ABG machines have co-oximetry in them. So if they can measure the methemoglobin level, because gas-Geyser syndrome is not uncommon, especially in the winter season. So that is one point that I think so is important. Rest all you have covered it beautifully. I don't think so anybody will have any doubt. And if you have doubt, I would advise you to again go back and see the webinar again. We'll share the screen. Going back again and again, you will understand better. So some questions are there. What should the baseline PCO2 be taken? Like we are taking 24 as baseline BICA.
So we take 40 as the baseline CO2. So 7.4 pH, 40 CO2, 24 bicarb. These are the standardized values that we take when we are trying to analyze your ABGs.
And the second question is, the compensation is decided by the return of pH or by the calculation of PCO2 as in metabolic acidosis?
So I think this is a very common question and it's a very good question, I say. So a compensated acid-base disorder does not mean that the pH will come back to normal. A compensation is the body's ability to act on that change. So the pH is not what decides the compensation. The compensation is decided by the values of CO2 and bicarb, and that will be decided by all those calculations that we did during our case discussions.
So that's why it's important you need to go back and listen to the webinar again, which we will share again. Only 2 questions till now, because it's all facts and you have given the facts properly. One more is there. That I think so they have already answered. Standard base excess and actual base excess. Which one?
It'll again depend on, there are 2 values. The difference what he's asking is that standard base excess is based on the standardized bicarb value and your base excess is based on the actual calculated bicarb value. So we usually take the standard value, not the actual one.
Okay, that is also done. I think so we have no more further questions. With that, I think so I'll ask Dr. Dinesh Goyal, sir, and Dr. Ajay to please wrap up the session.
Thank you, Dr. Manjinder and Dr. Narayanan, for a wonderful discussion and presentation. I hope this presentation will be very useful to all those working in the ICUs. And I request Dr. Dinesh to please say a word of thanks.
Thank you, Dr. Ajay, sir, and thank you, Dr. Maninder, our star. And this is a wonderful ABG session. And ABG is not only limited to the critical care unit, it is even to the pediatric OPDs also. Because sometimes we get the patient of failure to thrive, or sometimes we get the other patients RTAs. In that scenario, also we need ABG interpretation so that we can correlate those symptoms with the blood gases. So nowadays, ABG is not limited to the critical care units. Even we do advise ABG in OPDs. Second is that key interpretation of ABG is very, very important, from basic to very deep interpretation. Because sometimes only we can say acidosis, metabolic acidosis, and further interpretation is also very, very important nowadays. And even this knowledge should transfer to the residents, because many a time a small mistake in interpretation will give a wrong treatment to the patient and wrong guidelines. So this is a wonderful session by Dr. Manjinder Randhawa, sir, and very beautifully moderated by Dr. Narayanan and Dr. Sarkar. And on the behalf of IIP Delhi, I must say this was a wonderful, super duper session. And thank you so much. Thank you everyone for sharing your knowledge for the youngsters. Thank you.
Thank you. Thank you, everyone.
Thank you.
Narayanan, now you can go for the flight.
Thank you.
Happy journey, sir. Happy journey.
Thank you.
Thank you.